That looks great.
Okay. Um, so, I thought for this discussion, we'd kind of do version 2.0 a little bit, but maybe it's more like version 1.5 because I do want to review some of what I talked about in Texas with your group about sort of general behavior management strategies and maybe some of the examples we could discuss or the questions that might come up would be more relevant to the current state of things where kids are home a lot more than we're used to and we're having to form new routines and establish new patterns of behavior and things like that, which can be difficult for I think kids with WSS. So we'll talk about that. I also have to say I've had a bit of a title change since I saw you guys
Oh,
last, and so I've recently taken on a pretty different role in the Children's Hospital. And Christina, you don't even know about this yet because we haven't chatted in a little while. But I'm now the clinical director of our On Our Sleeves program, which is a big national program for community outreach and education around all things children's mental health. And so I still work part-time in the feeding clinic, but I'm actually not doing the intensive program anymore. So it's a really big change for me, but it's an opportunity for me to do a lot more things like this, honestly, which I really love this part of my job. And so just so that you guys know, you might see my name in other ways involved with this program about different educational opportunities out there, and forming alliances with groups like the foundation that you guys have and things like that around the country. So it's exciting change for me. Great time to do a job
Congratulations. That's
change.
awesome.
Yeah, thanks. Yeah, and it's a good time to change jobs during COVID when I'm here in my hidey
Yes.
hole at home, But timing aside, it's a good gig. So anyway,
Well, that's
um,
exciting.
yeah. So just an overview of what I was planning on talking about, and I'm going to do my best to get through this somewhat quickly because I feel like the more interesting part for me is hearing questions and discussion from you guys if you're willing. So, think of questions, you can put them in the comments, or you can, interrupt me if you want to, or hold on to them until the end and we can talk through things. So, but I'm going to do a little bit of background, review some definitions of what I'm talking about, discuss evidence-based practice. It's sort of like the foundation of our discussion here of sort of, how do we think about behavior change and trying to both eliminate behaviors that we don't really want to see anymore, but also just as importantly, how do we try and teach new behaviors and more functional ways of behaving? And then I thought I'd spend some time talking about aggression and self-injurious behavior today, just given that that's a unfortunately common concern with kids with WSS, and it's really hard to manage as well. So I thought we'd talk about that. And then some new wave treatments, and I mean that in a good way. What's the latest, greatest, different than our classic behaviorism and, books that have been out since the 70s on behavior change. And those are fun to talk about. And then I do want to just touch on medications because not that I prescribe, but a lot of parents either have misconceptions or just lots of questions about, what type of medications might be helpful and how do I consult with someone about that. So we'll just touch on that at the end. So just a little bit of background. Children with developmental and intellectual impairments in general are far more likely to exhibit behavior problems and especially more what we would call severe behaviors. And by severe behaviors, I mean things that cause danger or injury or potential injury to themselves or other people. And so those issues usually stem from the fact that it's more difficult for them to express themselves, to self-regulate, and to inhibit their moods and behavior than the general population. So, I'll talk in a little bit about what are some of the impetus or what are some of the reasons why children become aggressive, and you'll see that not all aggression is the same, and we don't treat it the same, and we don't think about it the same. So I'll tell you specifically what I mean. And then the standard practice is to do something, either applied behavior analysis or very similar, and to add on medication if needed. And again, at the end, I'll talk about what if needed means, because that should have a big asterisk next to it. And what we capitalize on are the learning styles of children with intellectual or neurodevelopmental impairments. And so kids learn differently depending on their ability level, depending on their functioning level. Even kids with similar diagnoses or similar conditions may have very different learning styles. And so we want to capitalize on what their strengths are and think about, how do they learn best? How do they respond to different types of instruction and different types of plans for learning new skills? And we want to work on that. So again, just some basic definitions of what I mean here. Behavior challenges, what I mean by that is any sort of challenge related to behavior that impacts their daily functioning. So this isn't necessarily, please go pick up your shoes. No, I don't want to pick up my shoes. This is more, I need you to learn how to brush your teeth, and you refuse to brush your teeth, so much so that we need some intervention to get your teeth brushed. Activities of daily living, in other words. And again, kids with WSS are known for having these type of challenges of being quite oppositional at times and just higher than the typical population. And so they often need a little bit of extra instruction and a little bit of extra help to, create patterns of behavior and create routines throughout the day that help them function the best as they grow older and go through school and into adulthood. Aggression. What do I mean by aggression? Aggression is any sort of physical or verbal behavior directed towards another person, sometimes towards the self when we talk about self-injurious behavior, but for the most part, we're talking about behavior directed towards trying to cause discomfort or injury to another person or themselves. And so we want to try and prevent that at all costs, because no one likes to be aggressive and no one likes to be aggressed towards. So we want to try and reduce that as much as possible. And then behavioral interventions in general, those are anything where we're applying what we call a functional behavior analysis or principles of reinforcement or conditioning onto someone's behavior with the intent of making a change. So, I either want you to do something new and different, and so I'm going to try and manipulate the environment a bit to get you to practice something new and learn something new, or I want you to discontinue something, and so I'm going to manipulate the environment and the setting so that you're not engaging in that behavior as much or at all anymore. And then a functional behavior analysis will actually just go into what that is, because this is really important. And a couple of these slides might look similar from the talk I did in Texas. But like I said, I want to run through it again really quickly for you. So a functional behavior analysis is really, we call it the ABCs. And because it's the starting point of how we think about making a change in behavior. We want to figure out what's the antecedent, what happens right before, what's the setting, what's the trigger, and this usually happens right before what is often a misbehavior. We can also use antecedents to create positive behaviors. When do we see that positive behavior most? And let's try and recreate that setting to get them to do that more often. The behavior, that's the thing that is easy for parents to notice. That's what keeps me in business. Parents come to me and they say, there's this behavior that they don't do or that they do all the time, and I need your help in stopping it or getting it to happen more. And that's usually the target of the intervention. And then the consequence comes right after the behavior. It can be positive or negative, and the most important consequence is often a caregiver's response. We'll talk about how that plays into things here. So these are types of consequences. And if you look on the left-hand side of the screen, we've got reinforcement. So that increases the likelihood of a behavior occurring, whether we want it to or not. This has nothing to do with the intent of the reinforcer or the punisher. It's what it actually creates. So sometimes we unwittingly reinforce behavior that we would really rather them stop. So a positive reinforcer is something that you give and it's a reward immediately after a behavior occurs, and that's going to increase them doing it in the future. A negative reinforcement we also call escape sometimes. And that's when something unpleasant is removed after a behavior occurs. So we're telling them, you have to brush your teeth, you have to brush your teeth, you have to brush your teeth. They have enough behaviors. We actually put the toothbrush down and say, fine, I give up for tonight, just go to bed. That's a form of negative reinforcement because they've escaped something negative that was happening at the time. And that's one of the most common ways in which negative reinforcement creates challenges for us as parents. And I raise my hand and put myself in that boat too, that sometimes it just doesn't feel worth the battle and you give up and move on. Punishment, it decreases the likelihood of a behavior occurring. And so positive punishment is something negative that you do after a behavior occurs. And that's pretty easy to understand. That's sort of your classic corporal punishment or discipline styles where you've done something bad. I'm going to do something that I think is aversive to you so that you don't want to do that anymore. Whereas negative punishment or a penalty is you remove something good. So I'm taking your iPad away, or you've lost the opportunity to have, your favorite stuffed animal or whatever it might be as a consequence for a challenging behavior. And so in manipulating these, it's usually the goal to try and influence behavior one way or another. Like I said, I either want you to do that more or I don't want you to do that as much. But inherent in there is the problem that when you're trying to eliminate a behavior, something usually has to take its place, especially for kids where communication or expression is a challenge. They're usually expressing themselves the best way that they know how. And so if you remove the way that they know to express themselves, even if it's not functional at all, like an aggressive behavior or tantrums or things like that, if you don't replace it with something, it usually just leads to more frustration and more challenges. And they'll just morph from one behavior into another challenging behavior. So we really want to take care to not only try and eliminate the bad behavior by, say, ignoring it or sometimes using a mild punishment, but we really want to figure out, what do we want them to do instead? How can I teach you a better way of behaving in that circumstance? And then reinforcing them the closer that they get to that behavior. So it might just be in the beginning that instead of hitting, they scream. But screaming is better than hitting. And so you might reinforce them and say, I understand you're upset and you're screaming. It was really good that you kept your hands to yourself today. I really appreciate that. And you give them a little reward, even though eventually we don't want to reward screaming. We want to reward more appropriate communication. But if you can reinforce a behavior to take the place of something that you're now going to ignore or not allow to happen, then you get what we call extinction, which means they just won't see the purpose in that behavior anymore, and they'll do something totally new. And that's how children learn that stuff all the time. If you think about your own children, they behave differently now than they did when they were 1 and 2 and 3, depending on how old they are. It may not be more or less functional, and that might be why you're here listening to me today, but they are different, and they've discontinued some behaviors and they've acquired new behaviors as they've learned them and as the environment has taught them what to do. And so we can be purposeful about that. So inherent in that process is the fact that it's not as easy as me just putting a little graph up there and telling you to go about your business, because kids are resistant to change, especially when it's something that is a deeply ingrained behavior for them. And so what we typically see is when we try and make a big change, like eliminating aggressive behavior or tantrums or sleep training or something like that, what we usually see is at the beginning, they think getting a reward for a new behavior is really nice until they realize that that means that they can't behave in their typical ways anymore, which is more challenging for them. And we see an increase in behavior that we call an extinction burst. And anyone who's worked with me, wink, wink, Christina, knows that this is something that happens sometimes once in a treatment or in an intervention, and sometimes happens on a more regular basis each time you try and make a small change towards your ultimate goal. And as parents and providers and caregivers, our job is to sort of ride that out with our kids and to be patient and mindful of them and to try and support them in coping with the frustration of being asked to change something that at that point comes second nature to them. And so you can see once you get up to that extinction burst at the peak there, there's this really beautiful decline in behavioral challenges. And then every once in a while, you might get what we call spontaneous recovery. I won't go into that, but that's sort of like, there's a big disruption in life and they maybe try and return to some of the challenging behavior that they've had before. A great example in feeding for me is that sometimes we'll have kids go through our program and do really well with eating and make a lot of changes, and then they have to have their tonsils out. And so when they get done with having their tonsils out, they're not so keen on eating anymore for a little while, but it's usually short-lived because they've already made the change. And so as long as we stick with it, they return to their positive gains and their good behavior pretty soon. So that is, 50 years of behavioral research and treatment in 10 minutes. And I know that's a really brief overview of it. I've got some resources that you could look up or read into that I'll share at the end. And of course, we could talk more questions if need be, but I want to get on to some of the new stuff too. So let's talk about aggression. Why are children aggressive? There are basically 5 different buckets of reasons why kids are aggressive sometimes, and they aren't necessarily mutually exclusive. So your children might fall into any number of these if they do act with aggression sometimes. So there can be some affective instability. What we mean by that is, mood swings, a lot of difficulty with regulating and self-regulating their emotions. And, a big group of kids who fall into this would be kids who have, a lot of anxiety around specific topics. And so when they're exposed to certain things, they have a really big spike in anxious thoughts and feelings, which leads to them maybe acting out when that thing that they're anxious about isn't removed. And sometimes, unfortunately, those are things that have to happen frequently, like brushing teeth, taking showers, getting dressed, eating, all of those kind of things. Cognitive disorganization. This is kind of a broad category for kids who either don't have sort of the cognitive skills or the cognitive organizational skills to be able to adequately maintain their behavior and cognitively decide on what a good response would be. And so they just default to kind of the animal instinct of protect myself at all costs, and that can turn into aggression sometimes. Poor impulse control. Of course, kids who have impulse control disorders like ADHD or things like that can be aggressive without thinking, but really this is just the idea of sometimes I act before I think, and we have ways of helping work back that process to where we think before we act, and that can help with the impulse control. Anxiety or hyperarousal can be its own category. So sometimes kids just have those hypersensitivities where they just really can't handle the stimulation going on around them. Kids with autism spectrum disorders would fall under this boat, I think, pretty consistently. And so their way of escaping those stimulus that they can't control or can't manage is to lash out. So you notice, all 4 of those have a star next to them because I think they could potentially be applicable in our conversation. The 5th one is predatory behavior. Those are kids who pre-plan being aggressive. They're victimizing others. We worry about that with things like conduct disorder and other disorders of sort of socially mediated disorders. So I think that's less an issue with the type of things that we're talking about today. That one's a little bit more scary as a psychologist, in all honesty. So when we think about managing aggressive behaviors in children and even adults with, cognitive or developmental challenges, the primary goal is de-escalation while maintaining safety. So, what I'm not going to do is teach you how to put kids and young adults into a nice hold that prevents them from moving and things like that. Because there are techniques out there that we shouldn't have to do that. And if it gets to that point, we should probably be involving another professional anyway at that point, whether it's, calling some authorities to come help, or whether it's going to the hospital if they're out of control that much. But there are lots of specific ways to manage aggression that don't include any sort of physical altercation at all. And so what we want to do is avoid that physical intervention, and ultimately prevention is the goal. So we want to try and figure out, using the functional behavior analysis, which we'll talk about on the next slide, when, why, how, what are the triggers, all of that. But then also, how does aggression play a role in their way of communicating and trying to get their needs met? What are they looking for here? So, and then parents setting firm limits and consequences with consistency is really key. And that can seem kind of like a no-duh statement, but sometimes with aggression, I find that parents shy away from wanting to set firm limits about that because they might think that it will just increase that behavior. But in my experience and in the literature, talking about the actual consequences of aggressive behavior and describing what aggressive behavior means can actually be really helpful in them understanding, here's how I behaved and here was the response for that. And I understand that relationship now. So we can talk about that a little bit more later when we go over some cases. So we want to consider the context, a functional behavior analysis, meaning, what was happening right before, and especially if it becomes a pattern of behavior, are there consistencies? Are there inconsistencies? Is there a setting that happens? Is there a time of day? What's the trigger? And sometimes you actually got to write it down and track it just to see, who's around, what's being talked about, what part of the day are we in, all of that stuff. And then when you think about the consequence, what happens right afterwards? Is there something that typically happens after they're aggressive? Do they, do we leave the grocery store every time we're at the grocery store? Or do we leave, the social situation if we're in a social situation and go home? Do they go to their room and have quiet time afterwards? Because that might be one of the things that they're seeking, or something that you could build into a preventative measure to stop the aggression from happening in the first place. And then, of course, like I mentioned before, we want to teach a replacement behavior, but not only in the moment. The right time to teach someone a new behavior is not when they're taking a swing at you or when they're hitting their head on the wall. It's when they're calm and relaxed and in the mood to learn, and when you feel like you could get some traction, so that when they are feeling out of control or when they are in that state and you can cue them, providing cues, modeling, and reinforcement for that behavior, it's not a new thing because they're not hearing you. If you've experienced this with your own kids, they're not listening to you rationally and thinking through their options. This is my last resort, and this is where I am right now. And so unless what you're asking me to do is easy and comes naturally to me, I'm not interested until after the fact. And then we're in a recovery effort rather than a preventative or a learning opportunity. So some cases, these are loosely based on actual cases that I've worked on. So, for this one, let's just take like a 12-year-old who hits their parents frequently whenever an electronic device is removed for any sort of activity of daily living or other activity. So, as long as they're on the iPad, everything's copacetic, they're good. As soon as they're asked, we got to put the iPad down for dinner or for getting dressed or showering or brushing teeth or sort of any of those type of things, it started off with just mild frustration and sort of like maybe taking a swipe at parents, but then it's morphed into a lot of aggression where parents are feeling hesitant to even remove the iPad. And so over time, the parents responded by giving more access to those devices and reducing potential aggression. So yeah, what's the harm in letting them watch it while we brush teeth? And what's the harm in letting them watch it while we eat? And what's the harm in letting them watch it in the car and downloading Netflix so that we don't have to take it? And, but what's happened now is that really anytime it's removed, there's a lot of aggressive behavior. So now the parents want to work on cutting back screen time because it's interfering with their activities and schoolwork and all of that. So what might we suggest? Well, of course, the first thing I'm going to talk about, what's the functional behavior analysis there? And, I made it a little simple so we can walk through it, but, the trigger is mom or dad or whoever says, time to put down the device, time to pause the iPad, time to turn off your show, whatever the words are. And that's a pretty quick trigger for, here's my response. I know what my response is that gets me the expected outcome, which is if I'm aggressive enough or aggressive frequently enough, then most of the time they'll just let me keep it. Okay. And so the inadvertent reinforcement, unfortunately, was the parents trying to sort of maintain the peace and let them have it a few more times here or there so that they didn't have to, incite that kind of frustration. But what ends up happening is that, it moves in the wrong direction and kind of gets out of control to where parents feel like they aren't in any, they don't have really a leg to stand on anymore. So, what did we talk about? What were the next steps? I always recommend gradual changes when something's difficult. And so, thinking about what's one other time during the day that we could pause it, or can we pause it for 10 seconds at a time? Just enough time for them to understand that pausing it is okay. And then they're going to restart it. And we reward them for pausing it for 10 seconds. And then we maybe pause it for more seconds. And we make it explicit and we use a timer. So we set the timer for 10 seconds. And when that timer goes off and beeps, they get to play the iPad again. And then the next day we do it for 20 seconds or 15 seconds. Right? And all the while you're reinforcing them through verbal reinforcement and hugs and all of that for any sort of incremental gains that they're making. And then, does the device have its own limits? So, iPads are great for this if you have one and if that's available to you, because you can make those settings so that it turns itself off and you have to take a break for a certain amount of time. And so you can actually program it to where the device is what's shutting down for a period of time, and it's less on the parents and more on, your iPad needs a rest. Your iPad needs to go to sleep now for a little while. And so that can be helpful in some instances. And then, of course, I'll harbor on it more, make sure to teach a replacement behavior. So if we're taking the iPad to do teeth brushing, is there something else that we could do, like hand them a stuffed animal or a stress ball to squeeze, or some other behavior that could replace the iPad temporarily so that they can get used to functioning without having that device. And then, of course, you want to cue them and reward more functional behavior, taking deep breaths, or, clenching a fist but not taking a swing at someone, right? Any sort of incremental change that works towards what we're ultimately wanting. So if we sort of take it up a notch, there's something called therapeutic crisis intervention, which I just wanted to float out there for anyone who, in the foundation that you guys might know about, or anyone on this call who might be in the position where aggression is a really commonplace thing in the home. There is a parent form of this training that people can participate in through Cornell University. We actually use this at Nationwide Children's Hospital in a lot of our inpatient units, and the staff are trained in this as well. And it's a specific type of crisis intervention where there's a focus on prevention and de-escalation. There's a family version that doesn't have a physical component, but the staff version does have a physical component because, these are unfortunately kids who are like rooming and boarding with us for some of these reasons temporarily. But there's sort of 4 tenets down at the bottom. It's based on environmental management. So how do we set up the environment for safety, for security, and to try and prevent aggression? And then behavior support, setting the limits, having appropriate consequences, how to avoid a power struggle. So, when to sort of go in and push a little bit versus when to come back and sort of de-escalate things in the short term. And importantly, there's an adaptation for children with communication difficulties, which include really any number of developmental challenges that cause communication to be difficult for them. So that's something that you guys could look into if anyone's interested. It's a really great training. It's been around for decades. It's not something new, so well validated. So moving on, talking a little bit about self-injurious behaviors, because this does happen sometimes. One of the most common reasons for self-injurious behavior is functional communication difficulties. Kids get frustrated, don't know how to express themselves, and so they engage in self-injurious behavior. And so this can be really distressing to both caregivers and onlookers. It takes a lot of forms between, biting oneself, scratching, head banging. I've seen a lot of unfortunate behaviors that fall into this category. And so our instinct as a parent, as an adult, as someone who cares for children, our instinct is to intervene, right? You see a kid who's doing something that looks like it hurts themselves, and what you most want to do is make it all better. And what we know about self-injurious behavior for all but a very, very small percentage of the population is that most self-injurious behavior is superficial or might cause minor injury in an extreme sense, bruising, or maybe a little bit of a scratch. And most of it is self-stimulatory or attention-seeking. And this is especially the case for children with intellectual and developmental challenges. Now, if your child or a child that you're working with or know is engaging in behavior that actually causes injury, if they're actually, cutting themselves or breaking the skin by biting, then we have some other ways of managing that. But that should certainly be something that you're seeking professional attention for, because those can get out of hand pretty quickly, unfortunately. But what we want to do is we want to remove the stimulus or the expected outcome, but don't placate them. So if you remove the iPad, I just love using iPads because they're like both the best and worst thing that happened to me professionally on most days. So if I'm removing the iPad as a dad and my kid's response is to start banging their head, then I don't want to just hand the iPad back, because that directly reinforces that behavior. Even though it gets it to stop and that makes me inside feel a little bit better and more relaxed, there are other ways of trying to manage that without sort of giving in to some of the reasons why self-stimulatory or self-injurious behaviors happen in those circumstances. So let's talk about another case example here with head banging. This is, for most parents, this is maybe the most concerning one, because it sounds and looks like they're about to crack their head open like an egg. And so I've worked with some pretty extreme cases of this and had some good success getting it to discontinue. So this is a close to true example of a 9-year-old patient who would bang their head on the wall or the floor. This would especially happen during meal times. I was working with them in a feeding sense, but it happened a lot of other times as well. And, they would hit pretty hard, and it made quite a noise. It was hard not to respond to it, but, parents were concerned about the injury. They would hand him the iPad back or a toy to distract him, which would stop the behavior, and the frequency increased over time. And so even as this kid got a little older, he started doing this multiple times per day, and it got out of hand pretty quickly to where pretty much any time he wanted a device or a toy, instead of going to get it or using any sort of communication, he just started banging his head all over the place. And parents would sort of run around figuring out what the closest distractor or favorite thing was, and they always had to keep it on hand. So again, what are our suggestions here? The first thing I said, which was really difficult, but we did this in a controlled environment during our intensive program, which is why I think it worked, was discontinue giving those distractors at that time. The only way to earn or have access to those preferred activities was to use more functional communication strategies. And so what we had to teach was better self-management strategies in between these episodes when he was calm, and the functional replacement behavior of using signs and sounds and pointing to a visual schedule about getting what he wanted at the time. And anytime headbanging started, instead of carrying around an iPad and toys, parents carried around a little pillow, and they would just nonchalantly slide the pillow under his head. And so it stopped making noise, and it stopped being the self-stimulatory thing that he was looking for. And so it really removed all the reason that he had to engage in that behavior. He wasn't getting what he wanted. He wasn't even really getting attention, and he wasn't getting the self-stimulation that he might have been looking for. And parents would just sort of move the pillow along. If it was on the wall and they didn't have a pillow, they just put their hand there. And it's actually amazing. If you cup your hand, it's really hard to hit it too hard and cause any damage to your hand. So even when they're trying really hard, if you just sort of cup your hand, they can sort of do all they want, and you're protecting their head and the wall or the floor. So it took about 2 days before he caught on, and then we started to give him cues and praising the replacement behavior. He would bang his head for a little while, and then he would I think he was doing a sign at first, but then he would say pat. And immediately someone would give him the iPad, we'd give him praise, high fives, lots of hugs, all of that stuff, and he would calm down. And before long, he wasn't doing the headbanging anymore unless he was really, really distressed, which I think was a little bit different situation for him. So, sorry to run through all this, but like I said, I want to make sure we have time to talk at the end as much as possible. So some new wave treatments that I wanted to talk through. One of my favorite ones is this thing called mindfulness-based positive behavior support. It was developed
it's something about, it's for Charlie's Wiedemann-Steiner.
Yes, it is. And so, mindfulness-based positive behavior support was developed for parents who have children who are more on the severe end of the autism spectrum, which, just because of the nature of the frequency of that disorder, that's where a lot of the research is in managing these types of behaviors. But they're typically applicable to a lot of different and, less common disorders or diseases or conditions. So I'll talk about that more in detail in the coming slides, but some other ones that are kind of more modern things are activity-based therapy. So, that's where kids are learning better self-regulation skills through actual activities, outdoor activities, and being able to manage their emotions through, team building and social communication activities. Those are some more some modern things that happen. Augmented communication, of course. Technology allows us to provide lots more ways for kids to communicate than they've ever had in the past. I've seen iPads where people can look at what they want on the screen and don't have to move or utter a word, and it'll speak for them. And so, just some of that technology is pretty amazing to help with communication if that's one of the main barriers. And then issues of social emotional development. There's a much greater focus on interventions for helping people become better about identifying, controlling, regulating, and expressing emotions. And so depending on where your child might fall on the spectrum of cognitive and intellectual functioning and behavioral functioning and development, they might be a good candidate for some of those instructional programs about here's what emotions are, here's how we express them appropriately and talk about them. And that can feel really positive to parents because it's a very educational type of strategy for managing aggressive behavior or extreme behaviors. But getting back to the mindfulness training with positive behavior support, there are two components. Mindfulness training has always been a thing. And, when we think about that, it's actually based in sort of Buddhist and Taoism and those kind of religious traditions, but it's been modified and modernized for more Western ways of thinking and philosophies. And so you focus on the four immeasurables: loving kindness, compassion, joy, and equanimity. So realizing, that those are four things that are desirable traits. And for us as parents, sometimes we lose track of the fact that, our job is really to exhibit those things towards our children as much as humanly possible. And then the three poisons, which are attachment, anger, and ignorance. And so these aren't necessarily meant to, have people practice different religious faiths or philosophies, but more to think about, how can I, in a moment of stress and frustration, how can I relax myself and think about, am I experiencing anger right now? Am I ignorant to what the true problem is underlying this issue? Or am I attached to some, is the reason I'm upset because my child, tore a piece of paper that is probably replaceable, even though it's frustrating? And is that really the reason why I'm upset right now, more than wanting to help them manage themselves a little bit better? So these are just things that they train parents in to sort of engage in the moment when you're getting really frustrated and upset about a behavioral challenge or something like that. And then it goes along with what's called positive behavior support, which I really love because it fits a lot with the crisis intervention mindset. But this is more thinking about just general behavioral support for children who are trying to learn and develop the best that they can. So we think about this kind of cycle, or these things that go together with, trying to create a setting event. A setting event is like, if I want them to do something, what's the best possible setting for them to do that? Is it when they're exhausted and when there's a bunch of people around and when I'm frazzled after work and when their brother or sister are running around screaming? Or is it when they're well rested, I'm feeling calm, there's some quiet time, and they're in their most comfortable space? So thinking about that when you're trying to change a behavior. Focusing on prevention and preventative efforts, which, again, I think that's a really important focus of how do we maybe not have them feel like they need to be in this position if possible. Having clear and reasonable consequences that are understandable and, function well for them and that they can understand. Teaching coping strategies. We all have things in life, and kids are no different, that we can't escape having them be frustrations in our life. So how do we teach them coping skills, and what level are they at with understanding how to implement those? And then the focus is on quality of life. We want to keep that in mind, that this isn't only about us feeling more relaxed and us feeling more calm and us feeling more successful as parents. It's about their quality of life too. And keeping in mind the fact that all of this energy and effort should also keep in mind, how does this improve their quality of life? And that can actually increase a parent's motivation to withstand some of the frustrating behaviors when they know that it's for, their good in the long term. So last couple slides, we're going to talk a little bit about medication. Like I said, for kids who have extreme behaviors and where there's danger, and when typical strategies that are non-medical are not working well, there are medications that are commonly prescribed to help manage that. And I've interacted with a lot of them, and I've had quite a few patients of mine who have used medications to great effect. Sometimes it doesn't go as well, and some parents really aren't interested, and that's okay too. But it should be a team decision whether this is going to be a road you go down. parents, I bold and underline you, because you guys are the most important decision makers for your children, and even adults who you might be caring for as adult caregivers. Providers, of course, have a trusted provider, or hopefully more than one. Developmental specialists, whether that's someone who's done assessments or worked with your child, or a therapist or something like that. And sometimes the school can be involved too if there's an issue of they're unable to maintain themselves in school because of behavior. That might be an influence on quality of life, because we want to base any decisions about medication on safety and quality of life first and foremost. We don't want to give medication for convenience. We don't want to give medication just because there's something that gets on our nerves that they do. This is really for those two reasons. And you start small. So frequently you evaluate the effectiveness of a small dose of one of the medications with really low side effects, and then you go from there. And most importantly, I think, find someone you really trust to know you and your family and your child and your wishes, to be the one prescribing. And sometimes that means you have to wait a little while to get in with the right person. But unless there's an emergent situation, it's worth a wait of a couple months to really feel like someone gets you and is involving you in any decisions you make about medication for behavior management specifically. I just want to talk through some general categories in case you guys hear about these or are wondering about how they might play a role. So stimulant medications, Ritalin, Adderall, really common, been around for decades and decades for ADHD specifically, but in general, they can help with self-regulation and inhibition for some kids. If there's an issue of just, I do before I think, and you just can't work past that, then sometimes these medications, I'd say that it kind of puts like a stall there, where in the moments between when I'm thinking about doing something and when I actually do it, there's a little bit longer gap for me to maybe consider an alternative before I just act out. And so for some kids, that's really effective. Those medications tend to have pretty low side effect profiles. But that's something to talk about with the prescribing physician. Atypical antipsychotics, which the minute I say that, people, usually get wide-eyed, but atypical antipsychotics, they are more modern medications than typical antipsychotics in the past. They have lower side effects, but they do have side effects, but they work really, really well with decreasing overall agitation and aggressive or acting out behavior. And so I've known quite a few kids who have been darn near unmanageable and at risk of institutionalization, or being placed in a group home because of the lack of control they exerted, where a little bit of Risperdal or Abilify or something like that has caused them to not only function okay in the home, but be able to return to school and function in social environments when that just wasn't really possible for them before. So, that's definitely not a first line treatment, but the doses they give are usually really small, and I've seen really, really awesome side effects. Another thing is that one side effect is that it tends to cause hunger. So for kids who don't do well with eating, that can be an unintended benefit of, all of a sudden they're interested in eating when they weren't before. And then the last one that I was going to talk about, now maybe there's another one, but selective norepinephrine reuptake inhibitors, SNRIs, those are atypical ADHD medications. Strattera is an example. There's not as many side effects because it works on a different system than stimulants do, but they're also not as effective for most people. So those are usually given as a second line treatment if a regular stimulant medication doesn't work for something like disinhibition or problems with self-regulation. So those are some of the most common ones. Of course, if we get into like the safety at home and safety for yourself, which I don't think is as common an issue, that's usually when someone is having to be hospitalized due to their behavior, there are higher level medications that they use temporarily, but these would be the most common ones that might be used on a regular basis. And then I just wanted to say that mood stabilizers and antidepressants tend to work for mood or emotion related behavior problems like conduct disorder, depression, things like that. It's not often used for children with neurodevelopmental challenges where behavior or aggression is the primary concern. Of course, if they're experiencing depressive symptoms or if they're experiencing, issues with mood problems, then those might be used for children or adults, but not as a primary goal of reducing aggression. And then the last thing, you guys, I'll email out my slides. I think Libby might already have them, but you guys are welcome to have these. I put some stuff about finding a provider in there, asking lots of good questions. And again, this is a little bit of rehashing from what I talked about in Texas, but I think it's really crucial that if you find yourself in a situation where you're having a difficult time managing things at home, managing behavior, getting any sort of change to happen, and you haven't yet found a provider that you feel like really gets the issue or has provided you with concrete solutions, I'd encourage you to keep searching. Just because you see a psychologist or just because you see a developmental specialist doesn't mean that they're the one out there that is right for you or your family. And so you can always search online for approved providers with your insurance company, but you can also search on places like Psychology Today. I'm not sure what the Scottish or British version of that is, but they might have some things on similar websites. And then questions to ask, like what type of therapy do you use? What experience do you have with children like mine? And what's your plan on working with, here's my concern, what's your plan working that with my child? You can ask directly, do you accept my insurance? And how will I or my spouse or significant other or family member be involved in sessions? And you want to look at someone doing behavioral or cognitive behavioral style therapy. There's different permutations of that, but you can ask when you call someone. And before you set up a first appointment, I would ask if it's a therapist, I see that you practice in this way. Is that a type of behavioral or cognitive behavioral therapy? And if they hem and haw or, talk about other things, for these kind of situations, I might steer towards someone different. They should be able to articulate how they work with patients who have similar challenges to what you're looking for. And I would be really wary of anybody who isn't focused on parent education for at least part of the behavior management, or who especially might say that parents or caregivers stay in the waiting room for sessions. And then other helpful professionals to talk to, developmental behavioral pediatrics. I will champion them all day. Their specialization is in the intersection between developmental and behavioral problems with pediatrics and medical conditions. And so they will often have all of the expertise that is necessary to both help with treatment, but also finding therapists and resources in your community if you can find one of these folks. And I have a website on the next page about that. Child psychiatry, if you're thinking about medication, any IDD center near you with specialized training and knowledge, and they're often linked with autism centers. But as I was saying, autism is just one of the more common developmental disabilities where behavior is a concern, but they usually have expertise in lots of different types of challenges. And of course, your local board of developmental disabilities is a good place too. And then final slide, a few extra resources. These are ones that a couple of them that we didn't talk about last time, but behavior management principles, that's about the positive behavioral support that I was talking about. And so you can read that book by Wheeler and Ritchie, who kind of developed that treatment. The website in the middle is the Society for Developmental Behavioral Pediatrics. And so you can find a clinician there. And then, the last one was one that we talked about before, Understanding Applied Behavior Analysis. That's a parent book about, how to understand, really getting down to the nitty gritty of trying to create behavior change at home. So all of those, I think, would be good resources to start with. So let me